Greetings from Indian Journal of Anaesthesia. I, Dr. Khushbu, will be discussing an original article from the April issue of Indian Journal of Anaesthesia. Can point of care ultrasound predict the difficulty in intubation? A prospective observational study. Airway ultrasonography parameters have been used to predict difficult tracheal intubation. However, the available literature on this topic is still controversial. Despite numerous individual and group predictors, identifying a difficult airway is not always possible, and challenges are often encountered during tracheal intubation. Ultrasonography of airway is a rapidly evolving modality for objective airway evaluation and identification of difficult airways. This study aims to assess the role of preoperative airway ultrasound parameters, namely the hyomental distance in the head neutral position, head extended position and the ratio, pre-epiglottic space, and the distance from the epiglottis to the vocal cord's midpoint, and the ratio in predicting difficult intubation. The primary objective of this study was to correlate these preoperative ultrasound airway parameters with Cormack-Lehane CL grading, and the secondary objective were to determine if any correlation existed between the above parameters and the intubation difficulty score, that is IDS, and to find the cutoff values of ultrasound parameters. The study was registered with the CTRI and approved from the institutional committee. It was a prospective observational study where 18 to 70-year-old American Society of Anesthesiologists Physical Status 1 and 2 planned for elective surgery under general anesthesia with conventional direct laryngoscopy and tracheal intubation patients were recruited. For exclusion, patients with head and neck deformities, previous history of difficult intubation, restricted mouth opening with interincisor gap of less than 3 centimeters, emergency surgery, or those requiring rapid sequence induction and pregnant women were excluded from the study. So there were 216 patients screened for eligibility, out of which 190 were enrolled and 188 patients were analyzed for the study. So these are the ultrasound images of the submental area showing the hyomental distance between the 2 points and those of the larynx at the levels of thyrohyoid membrane. So here the white solid line connects the two vocal cords. That is, we can see here the midpoint of the vocal cords EVC in the yellow solid line, and the dotted line indicated the distance from the skin to the epiglottis, that is pre-E area. The sample size was calculated using Stata for Windows software based upon a previous study where the mean hyomental distance differed by 13 mm between difficult and easy intubations. So with error probability of 5% and power of 90%, the minimum required sample sizes to evaluate all above parameters was 172, and considering a 10% data loss, a sample size of 190 was chosen. The statistical analysis was performed over SPSS version 16. So these are the demographic details of the patients recruited for the study and the CL grades and intubation difficulty scores of all the patients recruited in the study. So these are the figures depicting the correlation between pre-epiglottic space and the distance between the midpoint of vocal cords to epiglottis, and the ratios with the correlation with Cormack-Lehane grade and intubation difficulty scores. So the cutoffs were calculated using these figures. And this figure demonstrates the ROC curves, that is receiver operating characteristics curve analysis for the airway parameters. Therefore, the present study showed that the use of pre-epiglottic space, the midpoint of vocal cords to epiglottis distance, and their ratio was useful in predicting difficult intubation, whereas the hyomental distance is neutral in extended, or their ratios were poorly correlated with difficult tracheal intubation. The intubation difficulty score has shown difficult laryngoscopy and intubation from a different perspective, wherein the operator's skill, use of alternative techniques, and adequacy of muscle relaxation and CL grades all have been considered to define the difficulty in performing intubation. The authors suggest that the explanation of the study findings lies in understanding the processes and biomechanics of direct laryngoscopy. However, there were certain limitations to the present study, such as the exclusion criteria, which excluded the patients with limitation of cervical mobility or edentulous states and suboptimal interincisor gaps, and this may have limited its applicability to more complex airway conditions. Additionally, the ultrasound measurements were conducted by a single investigator to minimize the variability between observers, but this method makes it difficult to provide external validation of these results. Also, the study was conducted in the central Indian population and it may not apply to geographically different populations because of demographic characteristics and ethnicity variations. So, to conclude, the airway ultrasound parameters such as pre-epiglottic space, the distance between the midpoint of vocal cords to epiglottis, and their ratio represent the anterior complex or dynamic phase of laryngoscopy, and it correlates with CL grade and intubation difficulty score in predicting the difficult intubation. A cutoff value of more than 1.22 centimeters for pre-epiglottic space, less than or equal to 1.12 for midpoint of vocal cords to epiglottis, and more than 1.18 for their ratio is associated with the intubation difficulty score of more than or equal to 1 but less than 5. Also, the ultrasound measurements of hyomental distance in neutral position, extended position, or their ratio, which describe the static force, a static phase of intubation, poorly correlates with the CL grade and IDS. Thank you.